Good morning, everyone. My name is Craig Brennan, President of Living Positive Victoria, and I'm your host for today's official community launch of World AIDS Day 2021. Today's events are hosted by Living Positive Victoria in partnership with Positive Women Victoria, the Burnett Institute, the Doherty Institute, RMIT, the Alfred Hospital, Thorn Harbour Health, Vive Healthcare, Hiv, and the Victorian Department of Health. Before going any further, I'd like to acknowledge the traditional custodians of the land on which we meet and pay respects to the 5 tribes of the Kulin Nation. We pay respects to the elders of the community and extend our recognition to their descendants. The theme for this year's World AIDS Day is 40 Years of HIV, and where to next? This theme reflects on the fact that it has been 40 years since the virus we know as HIV was identified in the United States, and that after all this time, we are still in a pandemic that affects millions of people worldwide. It acknowledges that the immediate future can be unknown for many people living with HIV. It acknowledges that there are both challenges and opportunities regarding the intersectionality of HIV and homelessness, HIV and well-being, HIV and financial security, and stigma and discrimination still faced by people living with HIV. These issues in many ways influence how we as a community engage with our partners, such as research organisations, service providers, peer support organisations, and health services. The first World AIDS Day was celebrated in 1988, and the first red ribbon worn in 1991. World AIDS Day aims to encourage Australians to educate both themselves and others about HIV. By wearing something as simple as a red ribbon, you can show solidarity to those of us living with HIV. It can be a catalyst for conversations about why we still need to wear a ribbon and a challenge to ongoing stigma and discrimination. I wear the red ribbon as an act of remembrance for acquaintances, for friends, for partners that I have lost over these last 40 years. Glorious, funny, intelligent, driven, irreverent people who have never and will never leave my heart. For me, it's also a symbol of great respect and admiration for the giants who refused to be silent or compliant and shone the way forward. It is these people from which I take inspiration and work for a better future. Over the last couple of years, COVID-19 has highlighted the inequities and disruptions to services that many people living with HIV face. Ongoing divisions in Australian society, issues of disparity, fear, anxiety, and in some cases, a disregard for human rights are among the failures that are commonly experienced by people living with HIV. But COVID-19 has also shown us that we can be adaptable, that we are resilient, and has demonstrated truly the importance of community. These are the successes that people living with HIV are also very familiar. As a society, we at the moment have an opportunity to reflect and learn, and I hope we truly do so. So where to next? As a community, we must hear the voices of those living with HIV and how to best serve them. The principle of meaningful involvement of people living with HIV serves us well. It helps ensure that programs and strategies are relevant and effective. Meaningful involvement raises the visibility of people living with HIV, and it elevates our voices and experiences to help decrease stigma and discrimination. The response to stigma and discrimination is everybody's responsibility. Historically, this burden has disproportionately fallen on the shoulders of people living with HIV. As we move forward, we need to better develop frameworks of accountability to address this balance. There is still vital need to raise money, to increase awareness, fight prejudice, and improve education. I believe we must also place greater focus on and ensure that long-term survivors of HIV are not left behind. As the world marches forward, all of us must recognise the physical and emotional cost of living with HIV for decades. Ending the HIV pandemic also requires all of us to recognise and address the social challenges that block marginalised groups from equal access to services. At Living Positive Victoria, we are proud to serve all of our clients and help them live authentically by providing tools that they need to stay healthy and included. World AIDS Day is also a time to celebrate. The strength of the bipartisan and community-led response in Victoria must be commended. The community, and continuing to grow and acknowledge that the science of U equals U, undetectable equals untransmittable, enables people living with HIV to live without fear of onward transmission and to have happy, healthy sexual and reproductive lives that we deserve. Thank you all so much for joining us this morning, and thank you for taking the time to listen today. We will now take a short break as we go to our panel. No, it's my pleasure now to introduce our speakers for this morning's official community launch. We'll be joined by the Victorian Minister for Health, the Honourable Martin Foley MP. Minister Foley will remark on why World AIDS Day is such an important date. It's such an important date from both a personal and a point of view. After Minister Foley, we'll be joined by Victorian Parliamentary Secretary for Equality, the Honourable Harriet Shring MLC. Parliamentary Secretary Shring will provide a speech outlining the state government's commitment to the HIV community. I now welcome Minister Foley.
Thank you and good morning, everyone. I begin by acknowledging the traditional owners of the land and pay my respects to their elders, past and present. Unfortunately, I am unable to be there in person today. I want to thank Living Positive Victoria for once again hosting the launch of World AIDS Day 2021, a day of reflection and a time to remember friends and loved ones lost since the epidemic began. Today is about reminding all communities that HIV is still here, that it is treatable, and that there are supports in place should people need them. The theme of this year is 40 years of HIV, where to next? The first case of HIV was diagnosed in Australia in 1981, and the first Australian death from AIDS occurred in Melbourne in July 1983. 40 years on from Australia's first case of HIV, Victoria's HIV notifications are their lowest in 20 years. This is a result of the tireless efforts over decades by people living with HIV, their friends, partners, by effective communities, researchers, clinicians and governments. I am proud of what you have achieved in the fight against the HIV pandemic. It is through your advocacy that we have seen remarkable gains, such as PrEP being listed on the PBS, providing near universal access and becoming the most commonly used HIV prevention tool for gay and bisexual men. Victoria was also the first Australian jurisdiction to endorse the groundbreaking undetectable equals untransmissible, or U equals U, consensus statement in 2017. Our commitment stands today, and we want all Victorians to know that HIV treatments work, that it prevents transmission, and that the stigma and discrimination levelled at people living with HIV has no place in our state. Where to next? Well, for Victoria, this is maintaining and improving our world leadership HIV partnership model and a response to achieve our bold vision of the virtual elimination of new HIV transmissions by 2025. The Victorian HIV partnership is defined by the GIPA and MIPA principles. That is the greater and meaningful involvement of people living with HIV. These principles form the bedrock of our response and ensures community-led and controlled approaches continue to be a defining leadership feature of our model of care. We want to make sure that everybody in Victoria has easy access to high-quality prevention, testing, treatment and care services that are inclusive, supportive and free from stigma and discrimination that we know continue to be barriers to accessing services. It is my honour to work in partnership with you as we continue to ensure Victorians living with or at risk of HIV are supported to live their best possible lives. Thank you.
Thank you, Minister Foley. Now we welcome Parliamentary Secretary for Equality, Harriet Shring.
Thank you so much, everyone. I'm trusting that you can all hear me okay from Parliament House, where we have been debating the pandemic-specific legislation all night. I would like to begin by acknowledging the traditional owners of the land upon which we variously meet today. For me, that's the Wurundjeri people of the Kulin Nation, and I pay my respects to their elders past and present. And I would also like to acknowledge any and all Aboriginal or Torres Strait Islander leaders or emerging leaders who have joined with us today at this particular event. I also want to acknowledge and pay tribute to Christabel Miller and to Associate Professor Jen Power. It is so great to see such a significant lineup of speakers for today. I'm also really very, very keen to acknowledge the work of every advocate at a community level who's worked so hard to improve and to enhance access to services, to discussion around removing and reducing stigma, and also to lean into the sort of practical improvements that can and indeed should be made as part of responding to HIV, to AIDS, and to healthcare and better support services, not just here in Victoria, not just around Australia, but in fact around the world. And today, as we come to mark the 40th World AIDS Day, I'm looking forward to being able to continue that work through the Victorian Parliament, to continue to work alongside Minister Foley, and in fact to make sure that we get the resources and the policy settings right to be able to deliver really, really important reforms, and to be able to in fact deliver meaningful change from U equals U through to the way in which we've delivered policy reforms that provide better access to healthcare. These are the sort of changes that make an enormous positive difference to people's lives. To everyone providing care and support, everyone tackling stigma and discrimination in the community as we battle a pandemic, which for many people will be the first experience, but for so many people across the HIV community is by no means our first rodeo. So thank you to everyone involved in organising today's event. I'm sorry I won't be able to stay for it. You can hear the division bells going now as we keep debating this really important legislation on, of all things, the pandemic. I look forward to continuing to reach out and to extend support to communities, and affirm that our government will continue to support all provision of healthcare support, tackling discrimination and removing stigma wherever we possibly can. I'm proud to be a part of that, and I congratulate everyone in the process of organising today. I wish you all the best, and as an opportunity to reflect and to commemorate, my thoughts are with everybody as well. Thank you so much.
Thank you, Secretary Shing. We'll now take a short break to enjoy a moment with the low-res choir.
525,600 minutes, 525,000 moments so dear, 525,600 minutes. How do you measure a year? In daylights, in sunsets, in midnights, in cups of coffee, in inches, in miles, in laughter, in sky. In 525,600 minutes, how do you measure a year in the life? How about love?
from the Australian Research Centre in Sex, Health and Society at La Trobe University. Jen Power is a Principal Research Fellow and sociologist specialising in research related to sexuality and sexual health. Jen recently received funding from the Australian Research Council to study the impact of biomedical, biodigital and biomechanical technologies on the lives of sexual intimacy among Australian adults. She also has ongoing projects exploring the quality of life among people living with HIV, the social and ethical implications of research towards a cure for HIV, LGBTIQIA plus health and well-being, and fertility and reproductive choices amongst LGBTQIA plus communities. Associate Professor Power is joined by Darren, Bev, Heather and Adam to discuss the theme for this year's World AIDS Day, 40 Years of HIV and Well To Next.
Hi everyone, and welcome to World AIDS Day 2021. As you've just heard, we've got this fantastic panel here with us today. We have Adam and Heather and Bev and Darren. And these wonderful people are going to speak to us about their experiences living with HIV and also just reflect on, I mean, none of you look a day over 40, but reflect on the past 40 years of HIV. So I'm going to start by asking each of our panel members perhaps to comment on you know, the last 40 years of HIV, we've had this virus with us for a long time. We've had much more recent experience of another virus, I guess, so that comes into our reflections possibly at this time as well. But what's one thing you would like to tell people about what it's like to live with HIV in 2021? I might start with you, Darren.
Yeah, sure, thanks. Look, that it's very different to how I thought it would be 20 years ago when I was diagnosed. I was told that I originally had only 6 years to live when I was 28 and diagnosed in 2000, and I was shown all sorts of pictures of AIDS-defining illnesses, and like, if I would have known now that I'd be sitting here talking to people and talking about my life and the joys of life, the whole trajectory of my life could have been completely different. And now I can pretty much live unaffected by it. I can know that I can't pass it to my HIV-negative sexual partners. And I can do what I can to help other people who are newly diagnosed or struggling and support them. Yeah,
thank you. And would you echo those sentiments?
I would, thanks Jen. I feel with the advances of antiretroviral treatments, now I just take one tablet a day. My viral load is undetectable and I can't transmit it to anybody. And I think that's a very strong message.
Yeah. I'm going to come back to whether or not we feel that people are getting that message across the community, because I think that's an important question. But I might just throw it to you, Heather.
Yeah, well, today people who are living with HIV are living like long, happy, healthy, productive lives. For example, for myself, I'm 57. I've been living with HIV for 26 years. When I was diagnosed in 1995, it was a year before the discovery of effective HIV treatments. So then it was a death sentence. I was only given 5 years to live. There was no hope on the horizon. But now I'm a mother of three boys. I have a professional career. I'm a published author. But the one thing that we are still living with is HIV-related stigma, and that does affect all people living with HIV, some more than others, and particularly with finding an intimate relationship and that fear of being rejected, and that is really goes to the heart of what it means to be human, and so that's the big sort of the next step. And I think we really do need to sort out HIV-related stigma now. It shouldn't be here. It's been 40 years and it hasn't really changed.
Yeah. Look, I'm going to ask Adam to comment and then come back to that question about what you think that's going to take, actually, to create that next level of change. But Adam, what are your thoughts on the last 40 years?
Others, I mean, it's an amazing place to be, where HIV is considered a chronic manageable condition. People can take a pill. In this country, it's a level of privilege that's not afforded to so many other people, and it's fantastic. But similar to what Heather was saying, stigma and discrimination is one of the major barriers that we face. Each person's journey is very unique, and we still need to progress the work so that we can address some of these systemic kind of barriers that people are facing, so that we're all, optimising our quality of life and moving forward.
Yeah, thank you. Actually, I'm just going to pick up on that theme of quality of life, because it is something that's spoken about. The term's thrown around a lot in the HIV sector at the moment. And I don't necessarily think we always talk a lot about what that actually means in people's lives, what quality of life looks like when you break it down for people, you know, what is it? So Darren, I might throw back to you if that's okay. What do you think quality of life means for people? And what for you, I guess, are the basic essentials of a quality of life?
Yeah, thank you. Well, I have to say to start that my experience of life at the moment at 48, after living with HIV for 21 years, is probably the best experience of life that I've ever had in the place that I've arrived at the moment. In the background, the last couple of years, I've also been navigating through problematic substance use, and so I've had to really kind of look at this question of what is a quality life to me, and what does it look like, and what does it feel like, because in a sense, that's kind of been the antidote to the substance stuff. And so for me, what it was about has been really tapping into what my core values are, what's really important to me, who's important, what's important. And, you know, my life isn't about, you know, jumping out of planes and doing hugely exciting things. It's about tapping into those really important core values on a daily basis in small ways. And focusing on what I want, not what I don't want. Like, for example, in COVID, it was the beginning of this round of recovery, and I thought, well, lockdown, how am I going to kind of navigate through that? And I rediscovered I had this value of creativity. So I went to Lincraft before the Lincraft closed. I bought all this wool, and I needed scarves for my friends, and I sent them to them. And so little ways, but core values definitely for me.
Did you know how to knit before?
I didn't. No, self-taught, YouTube.
And how did they turn out? Were they
great.
good scarves?
Yeah, good. Yeah,
oh, nice
yeah.
Adam, did you want to comment on that issue as well, quality of life?
Yeah, I think it's around holistic dimensions of life. So looking at the spiritual, the physical, occupational relationships, all of that, and trying to maximise those dimensions. And I think moving forward, the pandemic has understandably had a massive toll on individuals, depending on circumstances. And mental health is one of the biggest things. So throughout the pandemic, I knew that as it drew on, it was harder and harder. I became somewhat socially disconnected from people, and that's so important to quality of life. So I would do things such as journal and try and actually focus on some of the positives. And like Darren said, what are my core values? Where do I want to end up? What do I need to be doing to actually have a fruitful life and things like that? So moving forward, I think is prioritising my mental health, the work-life balance, and yeah, so there's some of the dimensions. Jen.
What was that like during COVID for people, given peer connection, support, seeing people, particularly other people living with HIV, but just connections more generally? During COVID, that obviously all went online. Yeah, what was that like for people? Do you want to comment on that, Beth?
Peer support, very important. We had Zoom meetings, we had updates, and yeah, I just find peer support is really special. Yeah, really helps you. It's really helped me with my internal stigmatisation.
Yeah. And Heather, you obviously work in a communication role for Positive Women Victoria. Do you want to speak a little bit about the online?
Yeah, so we had a number of different like casual catch-up chats, get-togethers online, which was fantastic because it gave an opportunity for women, particularly those who live alone. I mean, I'm living in my house with 3 teenage boys, so there's never a dull moment.
Yeah.
But you know, you can imagine, say, for a woman who's living on her own and wasn't able to connect with people. I mean, this might have been the only time during the week that she actually got to have a conversation with other people. Like, I know it's not face-to-face, but it's kind of the next best thing. That was really important. So we held regular Zoom casual catch-ups. And we also held a couple of different webinars so we can kind of keep people informed about their health. So that one was on your gut health, and then another one recently on menopause for women living with HIV, and both were really well attended. And the great advantage I see that's come out of COVID is previously we would probably have held these events in person, so it means people have got to travel from regional areas into the city. Like, I live out of the city, so often I wouldn't go to these events previously because it was just too far. It's like an hour and a half trip, for an hour kind of get together. So actually opened it up and brought a lot more people together that would not normally have actually had that opportunity. So that was really fantastic.
Yeah.
And we were very lucky with Positive Women Victoria, because we had our retreat when we had that brief window of opportunity where we were out of lockdown. So this was fantastic. We had 30 women at Inverloch, and we had a fantastic weekend. So everyone was able to connect and get together.
Just in time before the next lockdown.
Just before the next lockdown. So,
Heather, do you think it'll continue? Do you think in some ways COVID's created an opportunity for some people to connect?
Definitely. I think we will continue to have our online catch-ups. We actually had two post-lockdown finishing, and they were still well attended, and the women who attended got a lot out of that. Some of them were in regional Victoria. There was one lady from Queensland who had previously lived in Victoria, so she was able to connect with women that she hadn't seen for a number of years.
Yeah.
So yeah, definitely, and particularly with the health promotion webinars, that's a great opportunity for people nationally, not just in Victoria, women and men, everyone can attend these webinars to learn about their health from experts. Like we had Professor Sharon Lewin for the gut health webinar, and a menopause expert from the UK. We would not normally have had those
absolutely,
people
the international and the high-profile guests for sure.
Yeah.
COVID's been a boom for that. Did you have other thoughts on that, Darren?
Yeah, look, I was a primary school teacher until COVID kind of came along, and suddenly being casually employed, I had no work because homeschooling, I went to homeschooling, so I was kind of at home. I applied for a job on the drug and alcohol team at Thorn Harbour Health, still wanting, having that need to connect with people, and I've been doing that now for about the last 5 months, and that's relatively mostly been online as well, but like Heather was saying, we've got a lot of forums for people to connect through, Zoom meetings like Rewired 2.0 for men who have sex with men who want to address their methamphetamine use, and all the client kind of contact has been telehealth or on Zoom as well. But it's amazing how you can still get that connection even through digital format, contact. So for someone like me who was relatively a hermit anyway, it's really kind of put me out there to make contact and really help me personally as well through that.
Do you think the online feels safer for some people? Like actually coming to a meeting or coming to a forum or connecting online has enabled some people to do it who wouldn't have done it otherwise?
I think it can, yeah, and I feel like even when you see a lot of people appear on the screen, you can feel as though you're instantly not alone.
Yeah.
And it's just in your own house, like you haven't had to leave the safety of your own home, so it's kind of that association building as well.
Yeah.
Yeah.
Thank you. So do you think there are lessons from the HIV response that we should or could or should continue to apply to our response to COVID? Bev, do you have thoughts on that?
I do. I think the media have got a lot to answer for. I think with the HIV pandemic, the Grim Reaper just put fear into everybody, and that still lingers today and doesn't help our stigma. And from COVID, they were just so focused on numbers, trying to scaremonger people. There was no correlation to population or percentages or previous known diagnoses. So yeah, absolutely. I think we need to censor media.
Yeah. So we should have learned that sort of fear-mongering just doesn't actually work all that well in terms of public health.
Absolutely.
Yeah. Adam, did you have thoughts on that topic, learning from COVID?
Yeah, I think there was a lack of health literate information around. So there was so much information, people were saturated on a day-to-day basis, it was hard to make sense. You get different media reports, like you were saying, and it's really, really hard to kind of determine what decisions to make. And then you get the media where there's a lot of demonising, there's a lot of moralising. People are plastered, in newspapers if they cross borders and everything, and that's quite difficult because it doesn't come to the why. Why did those individuals do that? What are their personal circumstances? And we have responsible media reporting guidelines to guide some of the language use and everything like that. And it feels to me a really missed opportunity, I think, to be able to actually realise that people are people throughout all of this. It's not just around a virus. Yes, that's important. Yes, transmissions are occurring. Yes, there is death and a lot of suffering, but at the same time, people are trying to do the best they can in the majority of circumstances.
And that can get a little bit lost in all the numbers and figures and focus on charts, I think.
Yeah.
Yeah. Heather, did you have other thoughts on the COVID?
Yeah, I just want to sort of share an example that happened in the small town I live in. The butcher in this town got COVID. And so there's so many rumours going around about the butcher, and one rumour was that he had died. He dropped dead and died, and because he had some sort of like attack, but it was nothing to do with COVID. This was at a medical centre.
He didn't die though?
He didn't die, no, he didn't die. There was just so many of these gossips, and then nobody would go to the butcher shop because all of this fear about stigma. So isn't there a correlation there between like HIV, like back in the day, if this person had been diagnosed with HIV and it got out in a small town, and this what does actually happen where there's a breach of confidentiality through, you know, a healthcare system in a health clinic or something like that. So, you know, this was stigma, and people were telling me about this in the town, and I'm just thinking, like, this is stigma, people. This is what, you know, this is COVID stigma, and we live with HIV stigma every day.
Yeah, I was thinking about that the other day. There was an article talking about how people banded together, a group of friends banded together to challenge COVID stigma. And I was kind of thinking, well, you know, that's over in a month, you know, and great. It was great that they were doing that and were aware of that. But yeah, I think there's something in that that's sort of not registering in terms of the impact of HIV, which maybe brings us back to some of the points that were raised earlier about, you know, how do we take the response to stigma, how do we challenge stigma and bring that sort of next level? Did you want to comment on that a little bit more?
Yeah, I think we just need to get the message out there in the community, just constantly. So through social media, just so people see it.
Yeah.
So they don't, you know, if you go out on the street and start talking to people about you equals you, they would just look at you confused. So they've never heard that term before. They don't know. Most people around know about HIV from the old days of the Grim Reaper. Yeah. That's where they still are. And then the young people, they actually don't even know what HIV is, like the teenagers, because they've never heard of it. There's no education. So I think if there's a constant, you know, over several years of some sort of advertising campaign, just subtly just raising awareness so people see it constantly, and it'll just kind of organically kind of sink into their subconscious, and people will then understand that, you know, it's not a death sentence. People are living long, healthy, happy lives. They're not infectious, and you know, the world will be a better place.
Yeah. In fact, we were speaking the other day in a meeting, and someone said they don't think they've ever heard a health minister or someone who's high profile, say in the health department or the health sector, actually saying the words, "You can't transmit HIV sexually if you're on treatment," or new treatments mean you can no longer transmit HIV via sex, or some very simple messaging that isn't really spoken. Do you feel like that is the case? I guess I'm throwing to anyone here. Did you have thoughts on that?
Yeah, absolutely. I think we need to get it out there, and we need to get it high profiled for the message to sink in. And there's new diagnoses all the time as well, so if we could educate everybody. But I think stigma, really, we should address it at medical professionals first. I think we need to get through the medical professionals, of which I am one. Yeah, and if we can get through there, then we can get to the general public.
Yeah, and that's a good point. I think we forget that doctors and other health professionals are just people, and their latest exposure to HIV might have also been the Grim Reaper. It's not necessarily kept up in the medical facility. Thank you. Did you want to?
Yeah, I think, definitely echo the words here, and that, you know, to break down the stigma in any way that we can. And I think the byproduct of that is that you rise hope, you know, the kind of like the seesaw. And I think anything we can do to keep demystifying it, like even talks like this, and keeping it kind of active and alive, and giving it some space, you know, and really putting it to the forefront, and avenues like Positive Speakers Bureau as well for Living Positive Victoria to just get people's stories and voices heard.
Yeah, so visibility is a big thing.
Visibility, yeah.
Yeah, for sure. Adam, did you have thoughts on?
Yeah, similar to what everyone said, it's around the visibility, it's around the real experiences, it's around normalising and painting a picture of what HIV means today is really, really important. I think there's something to be said for comprehensive sexuality education in schools. I know that there's a lot that's taboo, but when it's not talking about the relationships and providing that psychosocial context, there's something that's really lacking. It can't just be medicalised, it can't just be about STIs, it needs to be about real people and what it means. So that's really important. And I think that there's a real role for medical professionals to amplify community messaging. It can't just be up to positive people to educate and actually paint that picture. It's those with status, with authority, that can really elevate our messages and go and be our solid allies in all of this.
Yeah, thank you. So what do you see as some of the major challenges over the next few years for people living with HIV, but I guess also for the HIV sector? You know, what are the challenges in the HIV response? I might throw back to you, Darren.
Yeah, look, it's really just what I was saying before about keeping it kind of active and giving it space and keep demystifying it.
Yeah. Bev, did you have thoughts on that?
Absolutely. I think as we are ageing well and we're surviving beyond what they expected, we need aged care facilities, aged services to understand HIV. And I think a lot of those carers and workers have never been in contact with HIV, and there starts a whole new stigma again.
Yeah.
So a lot of education.
Okay.
Again.
Yeah. And what's that going to take? Sorry, I know that's the $64 million question, but how do we actually up that level of education?
I think education in the aged care facilities for a start. Like Adam said, in the schools, you know, we need to be out there and talking to people, and they can see real live, you know, people who have are living with HIV and ageing. Yeah, so yeah, education, being out there, being seen,
yeah,
and get the message across. And yeah, we've just got to make sure that people aren't treated differently.
Yeah. Yeah.
Because, well, a lot of the workers actually come from overseas where HIV, they're not, like Adam said, they're not privileged to treatment like we are. And so then it can be transmitted.
Yeah.
So, yeah.
Yeah, that's true. Yeah, it's very different globally if you're looking on that level. Thank you. Heather, do you have thoughts on that?
Yeah, I think the big issue for people living with HIV as we age is the effects of low-level inflammation on our bodies. So even though we're on medications and the virus is undetectable, but the low-level inflammation is still bubbling away in the background. So that's sort of doing some damage to like your heart health, gut health, and so forth. So it's about being aware of that, so that as we age, we can age well. So so it's like just having more knowledge and understanding of that. I mean, it's just something as I'm aging, that I'm starting to become aware of now. I remember the World AIDS Day event a few years ago. They had scientists talking about low-level inflammation, and I'm like, you know, you're just doing this so you can get some more funding, because the medications today are as good as a cure, and, you know, you're just trying to find stuff to research. But, you know, there is some truth in it. There's a lot of studies that have come out now about the impact of low-level inflammation on our body as we age. And we want to age well, and, you know, it's sort of can be controlled, you know, through diet and exercise and living well and less stress and all those holistic well-being things that we can do to improve our health.
Yeah,
yeah. It's like one thing with living with HIV is it really does make you become aware of your mortality, and when you're aware of your mortality, you then really focus on your health.
Yep.
And we become quite expert at health and well-being as we live with HIV.
Yeah, that's an interesting point. One thing I think that's come up in research on quality of life for people living with HIV, and one of the things that maybe takes away or, you know, detracts from quality of life is a kind of low-level concern or vigilance or worry about future health, about what health, you know, what might happen to someone's, you know, to someone in their future. Do you think there's more that can be done to kind of help people learn about their health or feel confident or understand, or is there some thing?
I think just being, the information about the health and ageing with HIV comes from the HIV sector organisations.
Yeah.
So I think people just need to continue to be engaged with their organisations. Like, a lot of this information we'll post like on our Facebook pages, or we'll have webinars. So it gives the people an opportunity to learn about this sort of information in a sort of easily digestible way. So we sort of package it up so it's easily understood. And like, when you know that, you can improve your health. But without knowing that, you're like a lot of people who don't live with HIV, how often do they get their cholesterol checked? How often do they have all these screening tests? So that's another thing as we age, is to really educate the health professionals and the HIV specialists so that we really have these screening tests, so we're aware of what's happening to our bodies.
Yeah.
So we're at an advantage in a way, because we have that and we're more aware of what's going on with our health before it becomes a problem.
Yeah, that monitoring. Adam, do you have thoughts on challenges?
Mental health, particularly in light of COVID-19. I think all of the data to date has alluded to poorer mental health outcomes for many people living with HIV. You've got a pandemic overlay and you've got a broken mental health system. So how do people actually get the support that they need when psychologists have substantial waiting lists, where there's out-of-pocket costs, where it's really hard to find a therapeutic approach, let alone a professional that really supports you, and where you can actually progress. So I see that as a major challenge, and I remember my psychologist recently talking almost like about another wave that we're waiting for, and it will be mental health. And that really concerns me for people living with HIV. It's not just about treatments, it's around the stigma, and then obviously the mental health implications of that stigma.
And what do you think, how could the HIV sector, for example, respond in terms of mental health? Is there enough conversation about that?
I don't know. I think that there's more advocacy work to be done, but I don't think it's just the work of the HIV sector. I think it's across the board in the health sector that there needs to be some reform into mental health, substantial funding that relates to Medicare items, that really supports professionals to remain rather than burn out. So
okay. Now listen, because we're in that enviable position of having more time to talk rather than less, and all the questions that we'd actually prepared, we've already got through. So I'm going to fire some unprepared questions at all of you. I hope that's okay. I'll put you all on the spot. But one of the things that gets spoken about a lot in the HIV sector, and so it should at this point in time, is diversity and the need for us all to actually recognise that the shape of the HIV epidemic in Australia is changing, that we're seeing an increase, relative to the overall pattern of diagnoses, an increase in the number of heterosexual women who are being diagnosed, an increase in the number of people who are not born in Australia who are being diagnosed. So, there's a group of people who perhaps the sector has not always been so well set up to reach or to respond to. And once again, I realise this is a very complex question and it involves a lot of sort of broader politics, but I wonder if, and I'm looking actually at Heather and Bev to start us off on this conversation, if you just have thoughts, thoughts on how we can reach populations, I guess, who haven't been well engaged in services, and perhaps what you think those needs might be. Like, what are we trying to address here?
I think we need to start at GP level. I think doctors need a lot more education. They need to be aware of testing for HIV. They'll do sexual transmitted testing, but they won't put in HIV with it. I think they need to be aware where to refer people. So I think there's a lot more work to be done out in GP land.
Yeah. Yeah. And do you imagine that there are still people who are presenting, who perhaps should be tested for HIV, but doctors, it's just not on their radar?
Absolutely. Absolutely.
And who would... Sorry.
Well,
I know you don't have all the answers.
Yeah.
But who should be responsible for training GPs? Where's that
the
momentum gonna
RACGP.
come from? Okay. And is that something that we could say here today? Let's put that on their radar. Let's be advocates.
Absolutely. Look, there's so focus with diabetes as an annual cycle of care. I think it's time to put HIV out there, have an annual cycle of care. Like Heather said, we have all our tests done, but a general GP can do all that.
Yeah.
Yeah.
Okay.
Yeah.
And Heather, what do you think about reach?
Yeah, particularly with people who have been diagnosed and they're from another country, when in their own countries, they don't sort of have screening tests. They'll only go to the doctor if they're sick, like if they're really sick. So it's sort of like changing the whole mindset so that when they're here, so they know that they can, go to their GP and have these screening tests so that they can find problems before they emerge and they become more aware of their health. And also connecting those people with the HIV support networks so that they can get information and they feel supported and they don't feel so isolated, because particularly amongst those communities, the stigma is just huge. The fear is just so, they're all they really have is their community, and if they're found out, then they're rejected from their community, and then what do they have? They don't have anything.
Yeah.
So it's about breaking down the stigma with the community leaders. So the community leaders and the church leaders and so forth, they know of this, and the information can kind of trickle down through the community to end that stigma. And it's huge. It's a huge task. But we have to start somewhere.
Yeah, that's right. And I imagine that some of the organisations who perhaps would be involved would be very local. So we're talking churches, local community centres, people who haven't necessarily had HIV on their radar, or small local groups. There's got to be some way of engaging with those organisations. I'm going to ask you another question, which is perhaps a little bit more personal. Just what does the future hold for you as a person living with HIV? I'm going to go back to Darren.
I think I'll be taking all the lessons that I've learned from it into my future. Like, HIV has taught me so many things about myself and so many things about my place in the world that I never dreamed would be possible. And I don't think those learnings would have come about by virtue of any other way other than HIV. And I kind of look at it like this: if someone put a magic button in front of me and said, Darren, if you press this button, your life will transform and you'll erase every memory of HIV, every experience of HIV, and you'll become the person that you would have become had you not been diagnosed. Will you push the button? I think I would not push the button. I think I'm so proud of the person that I've become by virtue of this. I've learned through HIV that I matter, that I believe in myself, that I'm worth it. And that's from what it's, the journey that it's taken me on. So
I think that's such an important point. I mean, you don't need to be, your life doesn't need to be perfect for you to be a good person and to feel that your life matters, I guess.
Yeah.
Whatever that means.
The future for me, I hope to live long enough to spend the kids' inheritance.
Yeah, great.
I enjoy the grandchildren, continue studying and hopefully retire.
What are you studying?
Transpersonal counselling and art therapy.
Oh, wow. That's amazing. That's great. I love that. Heather, what are your thoughts on
I'm with Darren. I wouldn't press the button either. I mean, HIV has really enriched my life. The people I've met, the opportunities I've had, I wouldn't be the person I am today. And, like prior to HIV, I just didn't have a lot of depth about me, and living a really hedonistic life, speeding around on motorcycles and so forth. But the diagnosis really made me sit back and wake up and realise that, I need to value my life. So I have more value of my life and also what's important in life. Not to be worried about things, to just live in the moment, all of that, and just to enjoy my children, and eventually hopefully they'll get married and I'll become a grandmother and retire at the beach somewhere, not in Victoria. So I don't like the cold. I'm from Port Douglas originally, so retire at the beach.
And I believe you've still sped around on motorbikes, though.
I still speed around motorbikes. I didn't lose that one.
What's your future looking like? Would you push the button?
It's taken me a long time. I think it is a blessing in disguise, like others say. The people that I've met, the work that I've been able to do, it's incredible. It changes everything. It doesn't mean that it's easy in the future, and I always think about what it might mean it's a part of me that will be there into the future. How do I navigate global travel? What does it actually mean in terms of criminalisation? But the one hope I have is for HIV cure. I do hope that scientists can progress their work and continue doing amazing things, and that we can get to the stage where cure is a real possibility, because it will continue to change lives.
Yeah, thank you. That's a whole other fascinating conversation, actually. Listen, I would just like to thank our amazing panel today. Thank you, Darren, Bev, Heather, Adam. Have a wonderful World AIDS Day 2021. I look forward to seeing more scarves. I'm glad that that's something that came out of COVID, because that's
On the list.
actually an excellent outcome from this situation. So thank you everyone for joining us for the official community launch of World AIDS Day 2021, and please stay with us, because coming up we have the 11 a.m. community forum. It's going to be moderated by Michael West, and the panellists include Richard Keane, Brent Allen, Kirsty Meacham and Simon Ruth. So thank you. Have a wonderful day.
Welcome back. I'm now honoured to introduce Michael West, who will moderate this morning's community forum. The topic for this morning's forum is HIV in 2031. On the panel, we have Richard Keane, Kirsty Meacham, Brent Allen, and Simon Ruth. Over to David.
Welcome to World AIDS Day, and welcome to the community panel with my esteemed panellists. It's a pleasure to be here and a privilege. I'd just like to acknowledge the people who, with HIV, who are joining us today, and also respectfully acknowledge friends, lovers, families, and others who may have passed from HIV over the last 40 years. I'd also like to respectfully acknowledge the traditional lands over which people are variously meeting today, and pay my respects to elders past and present, acknowledge the continuous spiritual and cultural connections to these lands and waters, and acknowledge these lands and waters are unceded. Super exciting to be here today. I'm Michael West, the manager of the Sexual Health and Viral Hepatitis program at the Victorian Department of Health. My thanks to David O'Keefe and Living Positive Victoria for hosting today's community panel. I'd also like to acknowledge this is the 40th anniversary of World AIDS Day and the 30th anniversary of the first wearing of the red ribbon. This year's theme is End Equalities, End AIDS. And as we've seen with COVID, viruses find fault lines and pockets of fault lines in society and amplify those for more vulnerable and marginalised communities. So the call to action to end inequality in order to address HIV, AIDS and the elimination agenda is particularly poignant at this moment in time. It's no understatement to say the world has been irrevocably changed because of HIV and AIDS. It has reworked global society and health systems and communities across the world. HIV has also united lovely people here today, clinicians, advocates, researchers, policymakers in an unprecedented manner. Unfortunately, it also has been at an unbearably or unbelievably heavy cost to families and communities. Central to the Victorian and Australian HIV response has always been a centrality of positive voices, and this is the heart leadership of our national and Victorian policy response. And so the principles of MIPA and JIPA really define how we have conversations and shape policy and responses in Australia. Just some context setting before we get to hear from our lovely panellists. Nationally, the Kirby's just released its data on HIV notifications for 2020. So we've seen a significant decline in 2021, about a 36% decline in fact, and that's been replicated in Victoria. Whilst I think the good news that that's a cumulative and accrued effort from PrEP, U=U, and enormous effort across different health services and communities. It also represents an interruption to, potentially an interruption to access to testing and treatment because of COVID over the last 2 years. And I think that's kind of highlighted by the CD4 count. 44% of the HIV notifications in 2020 were late diagnosis. So potentially that indicates that people aren't accessing the treatment and care and testing that they need. With not much further ado, I'll just do a little bit more context setting. So we're imagining into 2031. If we look at the last 5 years, and in particular the last 2 years, there's been incredible developments both at a social level and a political level. So in this country, we've seen a national marriage equality debate. There's been the historic repeal of gay offences in Victoria. We've had legislative reform to remove discriminatory HIV testing provisions that were a kind of moral hangnail from the 80s. PrEP was listed on the PBS. We have the clear science supporting U equals U, and we've had some really rapid legal advancements for trans and gender diverse communities. Terrific work. And then the last 2 years, we've had global disruption to our health services and communities from COVID. What can we expect through to 2030 if this is the slide that we're on now? So I think it'll be a dynamic 2020s. So I'll get to my speakers today because that's why we're here. On my left, first we have Richard Keane, who's the Chief Executive Officer of Living Positive Victoria. Richard was diagnosed with HIV at 19 years of age in 1989. He has been engaged in the community-led response to HIV for 3 decades now. Beginning in 1990 in the role of AIDS and injecting drug use educator at the Prostitutes Collective in Victoria, he remains a passionate advocate for marginalised populations and ever diversifying communities living with and affected by HIV in Victoria. Next, we have Dr. Kirsty Meacham, who's been involved in HIV-related journalism, advocacy, policy development since the mid-1990s. She's former chair of the then Victorian AIDS Council, now known as Thorn Harbour Health, and has worked for the Australian Federation of AIDS Councils as well as the National Association of People Living with HIV and AIDS. Kirsty is the Executive Officer of Positive Women Victoria and has a PhD focused on ethical dimensions of evolutionary theory. Her pronouns are she and her. Next, Brent Allen, who used to be my boss many years ago. Brent's pronouns are they, them, has been living with HIV for nearly 25 years and is involved in the community response to HIV for over 35 years. With a background in health promotion, education, community-based management and research, as well as policy and advocacy, their current work focuses upon efforts to build capacity of people living with HIV through advocacy, education and representation. They regularly provide technical assistance to global networks, governments, civil society and industry on matters of best practice in relation to HIV policy, programs, services and research. Last but not least, we have Simon Ruth. Simon is the Chief Executive Officer of Thorn Harbour Health. He has more than 25 years of experience in the fields of AIDS and HIV awareness, advocacy and treatment. This also includes alcohol, drug treatment, Aboriginal and Torres Strait Islander services, youth work and community development. Simon has worked in both public health and the not-for-profit sector. Since becoming CEO of Thorn Harbour in 2013, Simon has led the transition from the then Victorian AIDS Council Gay Men's Health Centre, which led the community response to HIV and AIDS in Victoria to the now Thorn Harbour Health. This transition has included expansion of service delivery to South Australia, and Simon has worked in both the MSM and injecting drug use services in HIV prevention. So these are our panellists today. We have a really dynamic current social and political context and health context, which sets us up well for the discussion today. So Australia has had a really robust, non-partisan support for the HIV/AIDS response, brokered by people like Neil Blewett, Peter Baum, Bill Botel and many others from the 80s and the 90s onwards. We've had national committees like NCAID and the AIDS Task Force, which has helped hold the policy conversation for Australia, laying the groundwork for successive governments to develop and fine-tune national policy responses that are picked up at state and territory levels with implementation and action plans. The strength of this commitment is evident today. Minister Hunt announced the Medicare and eligible access. People who are HIV positive and who are Medicare and eligible will have access to HIV treatments in this country. Terrific. That will greatly help our elimination agenda. Our first question for the day, though, is in relation to Australia's governance of the national HIV response. And this will be for all panellists, so jump in when you want. Australia is currently entering the final year of the 8th National HIV Strategy. This strategy spoke to the need to outline a framework for a high quality and coordinated national response. So, what's the report card? Has Australia reached this aspiration? If not, why not? First, I might ask Brent to lead.
Oh, you know, a score for Australia on meeting the national targets. I mean, I would probably give it a B+. I think that there is more we could do, but the reason I wouldn't go higher is because I think in the past few years, we've realized new aspirations, new targets that we didn't anticipate when the strategy was originally created 8 years ago. I think we're seeing advances in terms of PrEP, U equals U, great scientific advances around delivery devices, all of which are new to the context that we're dealing with right now. But yeah, I'd say B+. I'd give it a B+.
That's not bad.
Not bad.
In public health terms, that's pretty good. Any comments from other panellists?
Look, how long's the strategy been? It's been 4 years?
4 years.
I mean, it's been a pretty interesting 4 years.
Yes.
Yeah.
COVID has derailed everything in that time, and I think COVID has also put a very stark contrast on what is high quality and coordinated. If we had incorporated a saliva-based HIV test into COVID testing, we would have wiped HIV out in this country, and we didn't do that. So there's been great things. PrEP's on the PBS, home testing's available in pharmacies in the next couple of weeks. Medicare ineligibles will get HIV drugs, all wonderful things. Is it high quality and coordinated? I think we've now seen what high quality and coordinated means, and I'm not sure that bureaucrats and policymakers and politicians have the same sort of priorities around HIV that they have around other infectious diseases. And the question is, have we lost interest in HIV? You know, certainly 20 years ago, there was more interest in it than there is today.
I think one of the issues, and I will sort of come back to this with, later on in the discussion, is that the response has been fantastic in some ways and probably wanting in a couple of areas. And one important thing to focus on is actually health equity and the issue of who is still being affected by HIV and in what ways. So when Simon talks about a coordinated response, I mean, one of the things that comes to mind is the significant number of people who are diagnosed with HIV who have a wide range of social issues that sit outside of just the sphere of kind of HIV healthcare. So it's one thing to to be able to kind of get people tested and have people on treatment. It's another thing to be able to kind of ensure that people are kind of getting the justice that they need in relation to housing, employment, and freedom from stigma and discrimination. And the state strategies are excellent in their kind of aspirations around challenging and tackling stigma and discrimination. But one of the things that I would sort of want to say, because I went to my first ACT UP meeting in 1991 and stigma and discrimination was so rife and so real for people. And it astonishes me that we still have women who come into our service who feel the stigma in the same way that people were feeling it in 1991, and I don't think that's okay. And one of the things that I believe would sort of help in a kind of national response and a kind of coordinated response is a really strong message about stigma. And I believe that what could help is leaders actually standing up and making the statement that says, if you are receiving HIV treatment and you have an undetectable viral load, you cannot transmit HIV to your sexual partners. And I have never heard a politician say those words. No. And I think that those words would do so much to kind of set a stronger framework for people who are being diagnosed with HIV who maybe don't have those connections to an existing knowledge of HIV, which might be more the case for gay men and men who have sex with men.
Terrific.
I'd also like to reinforce the conversation that Kirsty was just having about undetectable equals untransmittable. I think within the bubble of people living with HIV and the broader community response, that's well understood. I've got to say it was an emotional day when the Honourable Jill Hennessy as Health Minister stood up in 2017 and spoke to accepting the evidence and the science around undetectable equals untransmissible. But apart from that engagement there, I haven't seen too many other people active in that space, and far too often stigma and discrimination, the burden of addressing those issues falls on the shoulders of people living with HIV disproportionately. And that's understandable because we're the most impacted. We want to see that change. But I think that sometimes if you're not directly affected by HIV, you can kind of switch off to those messages about positive people talking about their stigma and discrimination because it's not your lived experience. And I think we need some really strong advocacy and strong leadership to extend those pieces of information out into the broader context of HIV in 2021. I think as far as the national response is concerned, I think there's a couple of things I'd like to point out that have been successes and have been achievements. And we're talking in my bio about where I started my engagement in the sector, and that was at the Prostitutes Collective of Victoria as an AIDS and injecting drug use educator way back in 1990. I think we have seen almost virtual elimination amongst injecting drug users, amongst sex workers, and that's because we were really bold and we had a community-led response which engaged with those affected populations and had them develop the solutions that were going to, impact forward transmission of HIV. And some of those things still remain controversial. We've got safe injecting rooms, we've got a whole range of other harm reduction engagements that we've engaged across those areas, but we've seen astounding success in those areas on a global perspective, and it's something to be really, really proud of. But also to the aspirational goals that we set for each other and the bold targets, I think they need to be there. They really do drive us. A few years ago, when it was first said that we were aiming for 90-90-90, I've got to be honest, I was a little bit sceptical that we might get there. But that real emphasis of setting those bold targets gives us something to aim and drive for. But I don't feel that's the same with stigma. Stigma, there's always been a challenge to get to a zero stigma target, which has kind of been a nebulous kind of I don't want to use a gendered term, but it's been an aspirational target because I was going to say a motherhood statement, but that's really not appropriate. So I think there's still a lot of work to do there, and we have to change the ways that we evaluate and have accountability for addressing stigma across the whole of the response and across the whole of society.
Yeah, terrific points. So we've got a B+. People are still being left behind. Stigma is as strident as it was 40 years ago. We have an opportunity to bring the COVID response together with accelerations in tech and innovations in vaccine development with HIV that Simon's highlighted. And whilst we have aspirational targets, which are great, there's more we can do. So at a national level, if we've got a policy framework, we've got national research centres that provide us the architecture to hold innovative science conversations and work. Is there an alternate mechanism that's needed? We had crisis cabinet for COVID. Is something equivalent required for HIV to help coordinate, reduce duplication and implement the national strategy? We have a policy, but do we have an active implementation mechanism? And so kind of putting it out there to my panellists, what you think.
Well,
do we need something like that in this country?
This country has been at the forefront, the vanguard of a partnership response. There's no doubt about that. But when we're looking at something as complex as stigma and discrimination, and I echo what Richard's saying here, I think it is a difficult thing to challenge. I mean, it's going to take social change over generations, I would suggest, to get rid of stigma and discrimination. But there are other mechanisms and other targets we can aim towards. I would say quality of life, for example. You know, what is the quality of life of people living with HIV and those who are profoundly at risk of HIV acquisition? But the thing that I think I would love to see the national government think about is a whole of government response. And I want to say, you know, just to build on what Kirsty was saying, you know, people who are struggling with mental health, with homelessness, with insecurities around their, say, their residency. How do you look after yourself? How do you even expect a future to be successful when you feel like you're struggling? You know, a whole of government response to HIV is required. We've saw that with COVID. We know we can do it. And I think that's what I would challenge the government to take on board.
I think we're a victim of our own success. I mean, it goes without saying Australia's done incredibly well when it comes to HIV. You just need to look at our region. Some of our closest neighbours are in the middle of AIDS epidemics. People are dying every day of AIDS in those countries. And we've done incredibly well, but I think when we were in crisis, some things were more palatable. We would not be able to roll out needle exchange today. Look how hard it is to get safe injecting facility when all the evidence stacks up behind them. And it's much harder. The Jeffrey Robertson hypothetical, does Dracula have AIDS, which I think is 1985. A panellist says, and everyone agrees, we need to put needle exchange in prisons. I thought, 35 years, we've got absolutely nowhere
nothing
on that issue. We can't even get state governments to say they will investigate it anymore. We got close a couple of years ago with Canberra, but we're nowhere near that. And we need to have those tough conversations about what actually needs to go in policy. Everyone here knows how to stop HIV in this country. We just can't get politicians to sell that message to the public because they're too nervous about being seen condoning of drug use, condoning of homosexuality, condoning of a whole range of things that have or stigma attached to them. We need some bravery.
So we need political bravery, we need policy bravery, we need conversations that disrupt, but we also need to get out of our lane and to deal with the complexity that Kirsty's highlighted and Brent's spoken to. So we need new partners, perhaps in mental health, in AOD, and we need those people at the table helping to shape or own the implementation of the HIV response. So that wise words from our panellists. Our next question, Victoria's, and just for some context, we're home to one of the most culturally diverse communities in the country. We have 150, 160 different communities in Victoria. Over the past 5 years, more than 44% of the diagnosis in Victoria have been amongst people born overseas. So we're seeing shifting patterns of transmission, demographic patterns are changing. Of the cases born overseas, 57% of those, and Simon alluded to this before, are from Asia and Southeast Asia, where there are the response to HIV epidemic has been less successful than here. The next question then speaks to the heart of the HIV response in this context and in the context of MIPA-JIPA principles. So the MIPA-JIPA principles are central to the involvement of priority populations. Who do you think these priority populations will be in 2031? What will the sector need to do to meet the needs of these people and communities? And I might ask Richard.
Okay. I think there's a couple of things that we've probably learnt really quickly with COVID that need to be implemented a bit more strongly and a bit more directly in the HIV response, and that's making information available in people's language. So one of the big challenges for us as a community-based organisation, we've seen the communities that we engage with over the last 10 years diversify dramatically in all kinds of areas, in their age, in their cultural background, a whole range of factors that are very much more diverse than it was 10 years ago. And I think if I'm looking forward to 2031, I think that that's going to be absolutely central. So things like information on our website. At the moment, we've just kind of jazzed up our website at Living Positive Victoria, and up the top there's options for clicking 14 different languages to translate that information. The problem with that though is it's kind of linked into things like Google Translate and things, and sometimes those translations don't make a lot of sense when you're talking about really complex issue like treatment as prevention or U equals U and a whole range of other things. So, but what we've got is a community that's engaged, and to kind of develop those partnerships with our members to do that translation work, to feedback from us whether that makes sense, what do we need to do, how do we provide resources for our community to do that translation work themselves when we get members from those really diverse communities engaged with our organisation, how do we utilise their skill set and really make them feel like they're providing a forward contribution to the response as well, because I think we're seeing, you know, more than 50% of new diagnoses are from people that are born overseas.
Yep.
We're also seeing them in a kind of a really sharp wedge out in the northwest corridor here in our state, and the ability to build up partnerships with public health networks, a whole range of other ways that we need to get into where community are instead of expecting them to come to us as well.
I'm a little bit not wary, I suppose wary is the right word, wary or cautious about how we kind of think of priority populations as a concept, because I think that language came about, we're used to thinking of it in terms of numerically the greatest number of people impacted by or at risk of. Actually, we've got, you know, so when we look at, I think in Victoria last year there was something like 37 new notifications of HIV amongst women. So the numbers are very small. They're also, at least in terms of the women who come to seek services from Positive Women Victoria, so peer support services, 75% are women born overseas, principally in sub-Saharan Africa, but often also in Southeast Asia, and I think about 14 countries in the last year overall. So there's that aspect of it is relevant, because what we need to sort of start thinking about is that we're not used to sort of saying that well, the numbers of people might be very small, but the impacts are very big. So what we're trying to do in a way is kind of reframe the response from a kind of social justice kind of dimension that says you might be numerically small, but your needs are really important, and they're not being met, and they're not being kind of, you're not achieving equity under the current sort of approaches in some ways. And I think, you know, the same applies, for example, if you look at the breakdown of kind of percentages of risk and who is kind of being impacted by HIV. So I still think that probably some of the most underserviced and discriminated against people in relation to HIV are actually heterosexual men. And we say very little about heterosexual men in the HIV response, yet they are now about 25% of new diagnoses are heterosexually acquired diagnoses. So there are a range of people who aren't kind of that can kind of, depending how you kind of consider a population-based kind of framework, that they risk sort of being kind of left aside. But to me, your response isn't complete if you've shifted all of the burden and all of the kind of lack of sort of access to services to a small number of people in the population.
I think that there's one more thing I'd want to add, and that was 40 years ago, HIV and AIDS affected the icky populations. Mm-hmm. Those we didn't like, those we scapegoated, those that were the most marginalized. And what I'd like to ask the audience to do is to think about, who do we scapegoat most today? Mm. Who do we marginalize most today? Because they're the ones who are most at risk tomorrow. You know, the trans communities, the immigrant populations, those who are non-English speaking backgrounds. And in many ways, and I absolutely agree with Richard here, you know, the successes we made with sex workers and injection drug users, amazing. But it's a tenuous, amazing success. And if we continue to marginalize the most marginalized, then that's where our outbreaks are going to occur. Absolutely, absolutely.
Simon, any comment?
I think everyone said everything, really. You know, over time, if PrEP succeeds the way we hope it will, we'll see a drop in gay and bisexual men locally acquired HIV. So then people who arrive in Australia with HIV suddenly start becoming much more part of the PLHIV community, and we need to start thinking about how we service them. And with new and emerging communities from parts of the world that haven't had migration patterns into Australia previously, we need to start thinking about how we work with them and what we offer them and the services they need. But Brent's right, you know, if we elected a far-right government who, as in America, said, right, we're going to stop needle exchange funding, you know, we could have a drug user epidemic within 12 months. You know, we're one bad policy decision away from everything falling apart.
I think there's a couple of really, absolutely agree, the fragility of the responses. We need to keep investing the political will and the non-partisan response, and always look at and analyse who is most marginalised and why, and focus our efforts there. I think, Kirsty, your point's really interesting about priority populations, because I think that can fragment a response. Because we deal with clumps or cohorts of people, when in fact lives are messy and lives interact in all sorts of extraordinary ways. So that I think we probably, and your opinion on this is welcome, about focusing on intersectionality and diversity more strongly in our response, less so than cohort responses. But picking up on Richard's point, how do we, if gay men in the future have sustained a virtual elimination of new transmission, resident gay men, and then we begin to focus more on other communities that are more at risk, how do we use the wisdom and leadership of gay men and others in the earlier part of that epidemic, connect it through to the new populations that we would be pivoting our community responses to? So
there's some opportunities to, like, prep for travel. You know, we know a lot of heterosexual people pick up HIV when they're travelling around the world.
Yep.
They're not aware of the risks that they might potentially be in, and we're shortly going to have injectable prep where you get a shot in your backside and it lasts for 2 months. So, you know, if that becomes part of travel medicine, we might start to see some movement there on other parts of the epidemic.
I just think some key things around equity and starting to see people as an individual who have multiple intersections that impact on their lives and the way that they engage. And I think moving away, as Kirsty said, from that constant focus on priority populations, are we listing every possible priority population in our response and starting to kind of, I think with the privilege of being involved in what I think is a world-class response comes some responsibility as well, and that's to equity. And we need to look at the way that we evaluate our programs. We need to find new ways of how we are held accountable for equity and how we engage people in an equitable way into our services. And I think, you know, we talk about meaningful and greater involvement of people living with HIV. I think the next step up on that ladder is equitable involvement of people living with HIV. And I think, you know, why shouldn't we lead that discussion? Why shouldn't we start to develop those frameworks to ensure that equity is met across our response?
Excellent, excellent point. And not a question for the panel, but I do wonder over the next decade if we'll have a new population that we deal with, which will be a climate refugee population, who won't be defined by country of origin transmission, but will come to this country because of other circumstances. But that's just my bit of climate activism. Next question. So at 2020, 50% of people living with HIV were aged over 50 in Victoria. And I know at Living Positive, Burnett, Positive Women, Thorn Harbour, you've been doing terrific work in the area of living well and ageing well with HIV. So access to healthcare is important for an ageing population. And Brent, you spoke to multiple factors in people's lives that can influence health decisions and choices and action. What challenges and opportunities will the sector face in access in assisting an ageing population of people living with HIV, and how to address potentially complex healthcare needs in the future? I might ask Simon for your thoughts on that.
I was thinking about this question. I thought, would I have given any different answer 5 years ago? And I'm not sure that I would have. You know, we're learning a lot more. We have people, you know, we have diverging populations of people with HIV. We've got people who were diagnosed in the last 15 years who are probably doing very well. They're on good treatments. They don't have lots of comorbidities. And then we have people who were diagnosed in the 80s and 90s who were on toxic levels of certain drugs, who have lots of side effects from that. And as they age, we're seeing lots of other comorbidities go along with that. And we're learning a lot more about what it means to be on HIV drugs for 40 years. You know, the first population's going through and learning what that's like. We have all new partnerships we need to form. There is a small dedicated group, I think, particularly at the Alfred and the Burnett and places like that, looking at this issue. And our organisations are involved in that. But it's as people want to, you know, move into aged care and you know, age gracefully, you know, there's a whole range of new partnerships that we have to deal with. As people being forced into aged care, stigma is something we're going to have to deal with. Training aged care facilities, what it means to have someone with HIV in when the workers all still, and the other people in there still remember the Grim Reaper ads, and that's what they consider HIV to be. There's a huge amount of work to be done in this space. But it's possibly going to be with a group, and things will change drastically 10 years after that, because the younger people coming through with HIV hopefully aren't going to have the same sorts of health issues that the current group does, because they picked up HIV when the treatments were so much better. But there's a lot of work in that space, and we're learning a lot. And
yeah, and to link back to what you were saying earlier, Michael, about how do we carry over those learnings from that early period from gay men who were disproportionately impacted by HIV. This is one of those areas where that's occurring already, because that population is now ageing, with more than 50% of us being over 50, and the success we've had in recent years with reducing the number of diagnoses of HIV means that that cohort will continue to grow into the future. And I think, as Simon said, it'll be about the partnerships that we continue to build. So one of the examples that I might be able to use today is the prevalence of cancers amongst older people living with HIV. And that is still quite an isolating experience for individuals to go to. You're used to kind of being engaged with your community and HIV care, and it's quite ongoing and it's wraparound and you kind of feel part of it. And yet when you have a cancer diagnosis, sometimes you really have to deal with that. It's sometimes, for some people, it's a very solo journey, and that propensity to already be experiencing social isolation as you age. And so community connectedness, a whole range of other opportunities to extend that sense of partnership and agency within your own healthcare as you grow older. As we grow older, we start to lose a bit of confidence. We start to just hand over decisions to trusted professionals like GPs and everybody else, and that sense of partnership and participation that you had in your healthcare over your experience with HIV can begin to wane a bit. So it'll be up to our organisations to find ways to reinforce that strength and agency in your own aged care.
Ageing's already hard without HIV.
Yeah.
You know, it's complicated.
That's an understatement.
Yeah.
You know, leaving the workforce, losing your identity, changing your life. You know, there's a lot of difficulties around ageing already, and then you add in HIV, and particularly for a certain part of the HIV people living with HIV population, they lost periods of gaining super, and they were out of the workforce for extended periods, and heading back into poverty is a real issue for those groups. And so having governments cover Medicare co-payments is something that we'd really like to see going forwards. As you age, you end up on a lot more drugs.
Yes.
But I think that's where you also want a bit more of a consideration of how things work in a systematic reform way, because one of the HIV Futures women's reports kind of showed that that overwhelmingly women who are older with HIV, who are living with HIV, have a risk of either not owning their own home or not having a partner that they're sort of financially sharing with. So what do we know? We know that entry into the aged care system in a meaningful way is often predicated on home ownership and family support and family money. And so therefore I think we need to be linking up with other organisations who address people who are kind of dealing with those structural and systematic and barriers to the possibility of kind of entering suitable aged care facilities, for example. So it does link back to these more systematic reforms as well.
But there's a great learning we had through COVID, and some people would bemoan the fact that we moved rapidly into digital health. But there are pros and cons to what happened with digital health. Yes. Some people with HIV are saying it was horrible, I didn't get the care I expected, or that I was used to maybe, and others are saying it was fabulous. It was rapid, I could get what I wanted. I think the future here is, and especially for those who are aging, is digital health, and having digital health navigation, like we have peer navigation, and helping people understand the complex dynamics of how to get in touch with someone, how to get a result digitally, how to understand that digital result, how to engage digitally in healthcare, and having digital health nurses, I think, is a whole new domain we've never really thought about. Why wouldn't you have, as an aged care nurse, also have a digital health nurse who helps you understand the digital world, including how to use my latest iPhone? Can I just say, please, anyone, help me.
I think that's a great point, digital literacy as a part of access, and but also digital navigators, virtual navigators, because different levels of people's ability to engage with those new video platforms or digital platforms.
Yeah.
And I really like Richard, you were highlighting the kind of cancer pathway, and then other health issues and aged care and heteronormative aged care settings, and it says to me, given the Kirby's National Research Centre's study into stigma indicators, almost a third of healthcare workers have a stigmatising position in relation to HIV. So I'm wondering what we need to do with our healthcare delivery systems. So we're not segmenting HIV off because it's the HIV response, but we're embedding it in aged care as a mainstream issue. We're embedding it in cancer pathways, but at the same time we're addressing that attitudinal barrier or stigmatising attitude from healthcare workers that could present barriers to people accessing their healthcare needs. So I'm just kind of interested in your thoughts on, from your perspective, what do health systems need to do to create inclusive care services, whether that's aged care, cancer care, whether that's cardiac care?
Look at yourself, basically. Look in the mirror. Ask yourself why certain populations, certain issues challenge you. Where does that come from? Is it fact-based? Is it evidence-based? Or is it something that you just accept because you've never challenged it in your life before? I think infectious diseases of all kinds, including COVID, have challenged us to think about our vulnerabilities and our susceptibility. And HIV did that early on. COVID's doing that now. And I'm not sure if it's just healthcare providers, but any provider needs to look at, what are you so afraid of that you won't take a vaccine? Or what are you so afraid of that you won't serve someone with HIV? It's just, look at yourself, think to yourself, base your knowledge, base your decisions on facts, not mythology.
There's a stigma issue which we could talk about all day.
Yeah.
And until some famous people with HIV come out, we're probably not going to see a lot of shift there. Say what you want about, what was his name? The Hollywood actor who... Martin Sheen's son.
Oh, yes.
Charlie Sheen. At least he got us all talking about HIV.
Yes.
If nothing else, he got us talking about it.
Absolutely.
You can train healthcare workers though, but if they don't use the skills they learn, they lose them. So there's no point going to an aged care facility where no one has HIV and training them on HIV because they will all forget it in 6 months' time. So we sort of need to create centres of excellence. There is a rise in LGBT aged care and we will see those become better, but they won't serve all parts of the community that need them. And so, we're going to have a coordinated response and possibly look to some of the big providers and figure out ways to work with them. There's also all the called and ethnic aged care providers because as you age, you fall back into your first language, and that'll create a whole other bunch of issues that we're going to have to deal with, particularly as this population becomes more ethnically diverse.
And COVID has showed how there is a need to train your aged care workers well, pay your aged care workers well, actually give people the dignity of kind of understanding that they're doing a valued job,
essential
in the community, because that is that's still a significant kind of reason that I think that pockets of stigma and discrimination do exist. Yeah. And I think that goes across a lot of the healthcare sector too, because one of the figures that always still strikes me as being slightly disturbing in the stigma indicators is the number of healthcare workers who are quite comfortable to admit in an anonymous survey that they would treat somebody who injects drugs in a different way to the way they would treat other clients, and that they acknowledge that that's kind of stigmatising. So there are a range of ways in which stigma against the populations that are most impacted by HIV is still being kind of perpetuated right across the healthcare sector.
And I think it's got to come from two areas. It's got to come bottom up from the experiences that people are actually having when they engage there, and the opportunities for organisations like ours to provide online training platforms. You know, we're jazzing up our IT systems and adding a learning management system where we'll be able to provide training modules to community and to healthcare workers to talk about unconscious bias and what it's like to be on the receiving end of that. But at the same time, it also has to come top down, and we have to have particularly GPs providing information around treatment as prevention and U equals U, and not having those barriers of feeling, and I understand it because they're very risk averse, but we can't have those barriers coming in, and this is one of the concerns that has been raised recently with the religious discrimination laws that are coming up. We've all been in healthcare settings, well I have historically been in healthcare settings where I've had people use religious terminology about my acquisition of HIV, and it's, you know, that's what you get and all that kind of thing. My concern is that we could be moving just gently back towards that kind of realm where people feel free to either maybe not provide information about U equals U to somebody on a personally held value, and it also can impact on our engagement with multi-faith communities. When we talk about the diversity of our community, a lot of COLD community members, regardless of their own orientation or anything else, have faith as a central component of their well-being, and it certainly made me reach out and engage with multi-faith communities in a way that I haven't done, and I'd hate to see that hampered by the ability to enable them to just say no.
Yeah, I completely agree.
We also need a better understanding of HIV amongst GPs.
Yes.
You know, GPs support aged care facilities. Your average GP doesn't know a lot about HIV.
Yep.
And the Victorian data says that about 40-something% now of people are being diagnosed in low caseload settings. So the idea that people are being diagnosed by an understanding S100 prescriber who's got that body of knowledge is not to be relied upon, really.
Yep. And they're relying on the same knowledge that created the Grim Reaper, right? So things haven't moved. I think that there is a mandate for us to go into general practice and upskill general practice around this. You know, I watched a program last night, and you know, the young woman was speaking about the fact that she was demonstrating all the signs of HIV and was not tested for a long period of time, which led to profound ill health when she was eventually diagnosed with HIV. Yes, getting into GP practices as a mandate. It's mandatory for GPs to get updated on the latest information, because you know what, to be honest, U equals U, or undetectable meets untransmissible, it's oxymoronic. Yeah. You know, we spent years and years training people about safe sex, and that, you know, just hammering it into people. And now all of a sudden we're saying, you don't have to be so scared anymore. Yeah. What?
Yeah.
These wicked workforce problems or cultural phenomenon like stigma, that's our bread and butter. So it takes multiple activities from multiple players to continually progress the conversation. But I think I completely agree, primary care is underutilised. We need a broader capacity build in those settings, and a number of things, but we know that. I'm going to switch tact now. Partnerships, we love them. Sometimes we hate them, but the partnership response in Australia is defined by MIPA-GPA. It is non-partisan, and it's often talked about and held up as best practice in the world. Is that the case in Australia? Partnership, so it is, from your perspective, what is needed to create and sustain effective partnerships around tackling HIV, and do we have it right in this country? I might ask, any of you to be frank and fearless.
Everyone's about to jump in.
Yeah, we're all just like, let's lean back.
Okay. Partnerships are easy when everything's going well.
Yes.
You know, and I think in Victoria, and we hear this constantly from people in other states, in Victoria, you all get along really well, and it's really odd.
Yes.
And I think, you know, I think we're all basically friends, and we all get along really well. We trust each other, and we're open and honest with each other, and that makes life a lot
And
more
I take
easy.
a great sense of pride in those partnerships, particularly at the community level, but they extend beyond the people in this room. There's, you know, in medicine, in research, in a whole range of other areas, in every arm of the response. But I take particular pride in the community-led response, and examples of that are happening today, and they happened at the beginning of COVID. You know, we wanted to make sure that no matter where a person living with HIV was receiving their services, whether it was Thorn Harbour Health, Positive Women Victoria, Living Positive Victoria, that we're all on the same page, following the same course. So there wasn't any opportunity for a lack of continuity across the response and our response to those issues. And it's pretty similar coming out of COVID as well, as we start to learn to live a little bit better with that. And I take a great sense of pride. I've certainly experienced personal benefit from the collegiate relationship of people on this panel. But I think it's only when you step into the national environment, because we're used to it, I think it's only when you step outside of Victoria that sometimes you say, oh, but it's not to say that it's perfect. There's always that underlying little bit of tension, because each organisation has a slightly different remit and the area that they're funded to do and their line of responsibility, and there can be some tension from time to time, but we have a very candid and mature relationship that I feel can move us through those things.
I think partnerships survive on the smell of an oily rag, especially once they're established. But there's a big difference between a partnership surviving and one that's thriving and growing and changing and able to have a discursive dialogue, a critical dialogue with one another. And that is about the investment you put into it. If you just expect that your partnership's going to be fine for the rest of time, you don't have to really invest in it, well, ultimately, I think that that's going to fail. So, you know, if we want the partnership response in Australia to thrive and achieve what we've been talking about here today, then we have to give it love, give it sunlight, give it water. I'm thinking of a plant, you know, like we have to, it has to be given the capacity to grow. If you're not investing in your partnerships and you work in the HIV response, and that means monitoring them, getting together and talking about things, then you're not doing enough.
I also think we need to be sort of have practical kinds of outcomes for partnership. We don't, we've tended to have existing partnerships that are relatively strong in things like working with sex worker organisations or groups for people who inject drugs. And a shout out to Victoria for its fantastic partnership-based work on sex work decrim, which is like so important. So that's a really fantastic achievement. But there are places where we can develop partnerships. As an example, Positive Women Victoria is looking at partnerships with in the refugee health area. In homelessness services. I also think that family violence is an issue for all of our organisations. So, but maybe one way to develop partnerships is to do it based on kind of practical projects. So I'm all for kind of working on kind of joint proposals. There's a bit of grant money out there to do some really concrete things and bring in the right partners so that you're expanding your partnership base, but not just in a kind of let's have an MOU and set and forget way, but in a way that kind of says let's actually have a shared kind of policy vision or outcome from a concrete intervention.
I think you've got to not take them for take them for granted, and listen. We have had a bit of tension, not between us, but between us collectively and some researchers in the last couple of years around something they want to research. And I think they've been a bit shocked that we weren't completely on board, and we went, our communities are a bit scared of this issue. You need to give us time to move through this. And the response from the research area was, but you love us and trust us. And it's like, yeah, we do, yes, we do. But we still also are a bit fearful of this, and we'd like some time to process this with you before we jump on board. So I think it's always gone incredibly well, but
Yeah, and also to back up what Kirsty was saying before, understanding that you can't necessarily be all things to all people with being a smaller organisation in a larger response, and that those novel and bespoke kind of engagements and partnerships. We've recently signed a memorandum of understanding with the Centre of Ethnicity and Health, and we're doing reciprocal staff training across our organisations to bring their skill set into here, bring our skill set over there. So it's about not always thinking that you have to achieve those goals by yourself, but having a look at what's around and leveraging those relationships and strengthening those to help us meet the challenges of ever diversifying communities we engage with.
Yeah, terrific. So we've got to keep our partnerships fresh, give them light, look at our membership, maybe have outcomes focused to understand if they're effective and ways of measuring that. Your work as leaders of our community response is to juggle competing agendas and land the shared vision for the work that you've got to do. So I think that'll always be the inherent tension of the partnerships we have. So I think all of those are wise words for how we negotiate, manage, invest in and grow our partnerships. And on a Victorian note, I've always wondered, we have, I wonder if gender is an influence here. We have a lot of women in leadership roles in the HIV sector in Victoria, perhaps more so than other states and territories. So I kind of wonder if that's something that influences the collegiality of our relationships in Victoria.
But you said it before, you know, we have a very diverse community to draw upon in Victoria. And I think what you're seeing is not just a gendered response, but a multi-ethnic, a multi-gender, a multi-sexuality response. You know, and it's our diversities that make us strong, not our similarities.
And we are the leaders, but we're also membership-based organisations. And if our members say no, it doesn't matter what our views are. The answer is no.
Now we're almost at the end. I've taken us off script multiple times. I didn't get through all of the good questions that were provided, but it's been a great conversation. I think I would like to end on kind of an open question, and not really about achieving elimination and what that would look like in Victoria, but from each of your perspectives, what are your opportunities, silver linings, hopes for the next through to 2030 for the HIV response and for your participation in that? Or you could speak about challenges, but I kind of like to leave on a buoyant note. So opportunities and challenges, hopes and fears for the next decade of your response.
I think ending HIV is tangible rather than aspirational. If the right emphasis and funding is provided in the next 10 years, I do honestly believe that we could virtually end HIV. It won't go altogether, but I think the incidence of it will be so low into the future. But again, to balance that out, my concerns are as we start to get those numbers down, and what is the number of virtual elimination that we're prepared to accept, what communities are left behind in that number, and instead of a reduction in stigma, does that then magnify stigma of those remaining few people that will be seen as the reason we haven't ended HIV? Does that then refocus on those marginalised communities and potentially stereotype them and marginalise them further? So I do believe it's achievable, I really do.
Cautious and wise words.
Yeah.
My hope is in the numbers of people who are getting new notifications is decreasing rapidly, so I hope that can be sustained. The other hope with that is that anybody who does get diagnosed with HIV does so knowing that they can have a stigma-free and quality life beyond just treatment.
Yeah, I would pick up on the quality of life. I mean, HIV is not going to end virtually, technically, literally, unless we involve people living with HIV, including the communities that are difficult to locate, difficult to provide service to and engage with. We have to work beyond our normal bounds. We have to, if we're going to end this epidemic.
Thanks, Brent. I agree.
It would be great to get somewhere in stigma, and the populations we work with, and not just us, but also Scarlet and Vixen and Harm Reduction Victoria, we work with stigmatised populations, and it would be great to shift that. And I think Victoria is the place to do that. We've seen a lot of movements, particularly under this government, particularly in the LGBTI space. We've seen those movements. Are we the right organisations in 10 years? Who knows? If we'd done this 10 years ago, we'd have Straight Arrows, Can and Yeah sitting with us. None of which are around anymore, so maybe we aren't, or maybe our organisations will be something different. in 10 years' time. But it would be, you know, we're at the point now where we need investment. We don't need money being pulled back. We're getting to the really hard end.
Yeah, it's more difficult now than it was 10 years ago. Way more difficult.
Yeah, we need to go out now and find those people in the community rather. They no longer just come to us. So, you know, and we're actually getting down to individuals and trying to figure out what's going on in the outer suburbs in this location. You know, so that requires more money and more investment because we can't abandon what we're already doing. If we abandon, you know, the campaigns that we run and the support that we provide and the needle exchanges that we run, we'll actually get a new epidemic created over here. So, you know, we can do it. We just need.
Absolutely.
We've heard it today. The elimination agenda is achievable. I completely believe that as well. There will be increasing complexity in the future that we will need to turn our resources and attention to and understand better in order to respond to those people and communities that may be the 5% that is virtual elimination, and how do we reach those people? I'm heartened by each of you continually adapt your response and your thinking in relation to the new data that you're receiving. And I've seen that with each of your agencies. So I think you are the agencies that will see us through for the next 10 years and are the leaders that we need to have at the table helping us to make the decisions that we need to make. So thank you for today. It's been an excellent conversation and I've really enjoyed being here with each of you.
Thank you, Michael.
Thank you,
Michael.
I'd like to thank Living Positive again for hosting us today and just give you a reminder that we have the Hiv research event coming up at midday. I think our Choddy, Chief Health Officer Brett Sutton will be delivering an opening address, and then we have other leaders, clinicians and researchers from the HIV response in Victoria who will be speaking at that research forum this afternoon. Really exciting schedule of events for the rest of the day. Thank you for joining us.
Thank you, Michael, and thank you to the panel for your contributions today. I very much enjoyed that discussion and the depth and the diversity of insights that you brought to us. This concludes today's official community launch for World AIDS Day 2021. Thank you everyone again so much for having taken the time to join us, and I hope you enjoy the rest of World AIDS Day. Thank you.